Probably did. I don't know if I saw this before or not. This is you. Go in. I'll change the name to Unit 4. Here, respiratory outline. Ta-da! Thank you for opening that up. Here it comes. Some years ago, I have basically outlined the chapter. Same thing that I've done before with some of the other chapters. No extra charge to you. This is some of the stuff we're going to be going over. Okay? All good. And it has both the anatomy and the anatomy it begins with, of course, and subsequently leads to the physiology. You can see here, and it's rather thorough. Right? Chronic obstructive pulmonary disease, emphysema. So a lot of the stuff that's covered, not in the same order as the Welsh Hole PowerPoint, but it should make for interesting reading. And as always, this is where you find test questions, so you should be looking through that. Okay? So, forewarned, as they say, is forearmed. Let us begin. So I threw that out there, and I'll have to put all those PowerPoints up on the other crew's thing as well. Here we are. We kind of looked at this a little bit as we were leaving. All the different things. I talked about the anatomical bases involving the eustachian tube and involving the right side main bronchus, and we'll get to that in passing as I saw. So my plan is to sort of go through the anatomical rather expeditiously because I don't want to emphasize it in a class that we should be basing mostly on the physiology, but it's important, and we'll go from there. So, and I do not spend a lot of crazy time going over things that are fairly obvious. Okay, yeah, the nose, openings for air, and basically, to all the commercials you hear, it's your air filter, and it's got the nose hairs, it warms the air, it moistens the air, etc., all that good stuff. And the nasal cavity, bigger than you think, and obviously divided by the nasal septa. There's a cartilaginous portion and a bony portion that you have. Certainly the bony portion you're familiar with the vomer and the perpendicular plate. I know it's Anatomy 1, a long time ago, galaxy far away. Okay, and the conchae, the turbinate bones are just basically creating surface area. And that's about as much as you have to know. And as you can see, smell is a little bit more superior. And they're a specialized receptor that's designed for smell. The vast majority of the upper respiratory system, okay, including most of the throat, which is the pharynx, the nasal area, down to the trachea, is highlighted by pseudostratified ciliated columnar epithelia. You must know that. That's the predominant epithelia. It's got those wonderful cilia, columnar epithelia. Some of them make goblets, are effectively goblet cells, unicellular glands that secrete mucus. And the whole ball game is the mucus is, I told you about this in micro today, sticky. And trap stuff, and the cilia, like little oarsmen, all their oars are going in the same direction. From your nose, they're going towards your mouth. From the back of your throat, they're going towards your mouth. From behind your larynx and the rest of your throat, they're going up towards your mouth. So we can expel them, swallow them, get rid of them, any and all of the above. Okay, so please remember that. Perhaps dust, pathogens, sweep it away, whatever. So however you get rid of it, one gets rid of it. And all of this is things that I talked about in passing before. So it's a very interesting area. It's interesting how some of the epithelia will expand. Typically one side, particularly if you have inflammation, it's almost like the way we do it is one side expands and another contracts. You ever notice when you have a cold, when there's a bug going around, all of a sudden you can breathe out one side of your nose, and then all of a sudden that gets clogged up and magically the other side clears up. It's almost, we do that almost, it's like a pre-programmed thing. It's very interesting how that all works. I think we underestimate the importance of just how important basically the ingoing air is. And this is our typical inglow where we exhale mostly through the mouth. So the mouth is sort of indirectly respiratory. We consider the mouth mostly when we look at digestive, because if you want to think of it as the primary function. I don't get a lot out of this diagram. Okay, I mean, there's tonsils back there, and really what you begin, so you can effectively, what we do see in and around the frontal bone, and I'm back to that old anatomy again, frontal, ethmoid, sphenoid, maxillary are the four bones and there are sinuses, little pockets with air and fluid that help our voices resonate and all that good stuff. And when we have a cold, please how you have a cold? Because you're feeling, and that normal tone and whatever sound that one's voice has is altered because of those. They're called paranasal air sinuses. They can get infected. They're like a blind cul-de-sac going off the nasal cavity. You have another one that goes up to your eye, the lacrimal duct, the tear duct. Usually when you get eye infections as a little kid, rubbing their eyes. You get eye infections as an adult, typically they're coming up through sinus infections and nasal infections, interestingly. And lastly, and perhaps most importantly, the auditory tube. It's like also known as, it's the auditory tube, the eustachian tube, the pharyngotympanic tube. I'm sure there'll be 6 more names in the medical literature that you can find, but that tube is really just a pressure outlet. Okay, and again, if you remember with my discussion the last time, that sort of anatomical passageway that facilitates little kids with ear infections. Okay? Really an important area. That's something for many of you, if you're going to be treating children, that's a big pain in the neck. Okay. Parents just drive them crazy. All that stuff. So here you are, particles, fluid. Here you can see the cilia that are there. They're very well organized. You might remember why it's pseudostratified. Not all of the cells reach the top, but all the cells are attached to the basement membrane. So, but because they don't all reach the top, the nucleus appears to be at layers, hence the term pseudostratified, but it's all one layer anatomically speaking. I've already mentioned it 3 times, there's a test question. Okay, it's like when you get to digestive, the hallmark of the respiratory is pseudostratified ciliated. With digestion, the hallmark is simple columnar. Know your lining cells, please. So here's the paranasal sinuses, mucus, reduced weight of skull, resonate the voice, and blah, 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 sinusitis, blockage, all that. I have that now. I should have sprayed my nose before I came here, showing you some neat views. If you want to remember the 4 bones around the nose, use FEMS, FEMS, frontal, ethmoid, maxillary, sphenoid. No extra charge for that either. Don't tell Sydney because she's not here. Don't tell your other partner in crime here. I don't like this part. Please. I mean, don't smoke. Don't be, I'm trying to think of the right asshole like me. And don't smile about that. Slow, progressive, sometimes deadly. Slow, and this is the big problem. When I would get a cold, months, and I'd be sitting there trying to see patients and bringing up all sorts of unpleasant stuff, it's not a pleasant sight. I wouldn't have had me for a doctor. So smoking slows and eventually paralyzes cilia, and basically now you get more stuff. It's sort of self-perpetuating. The more smoke, the more frequently you get infections. The more infections you get, the easier it is to get infections. And this is effectively this chronic cough, which, even though I'm coughing more with allergy season, something I no longer have. And unfortunately, now we can access these respiratory structures. There's chronic bronchitis. And all of these lead to significant problems. The largest problem is the destructive nature. When we get into the interior, when you see the alveoli, I'm sure you discussed them in lab, those little pockets, balloon-like, grape-like clusters of cells. And the cells are arranged almost like in a circular, like a grape-like fashion, except the grape is in one cell. I guess the analogy, I think the best analogy would be like a puzzle ball. If you ever have like a jigsaw puzzle forms a ball, and they're kind of fun to play with. That basically is what they're like when you think of it cellularly speaking. They are just, they get so damaged and the walls get so damaged that air gets trapped. And what does emphysema mean? Trapped air. Emphysema has nothing to do with the lung. Emphysema means trapped air. So you have to specify, for our purpose, if someone says, oh, they have emphysema, they're talking about the lung. Okay. But I mean, there's other kinds of emphysema where air gets trapped subcutaneously under their skin, for that matter. Things like gas gangrene. So results in, and because of all of these things, now we begin to see a greater number of abnormal cells, replacing them. And I mean, I'm happy to be on the correct side of the 80% so far. Okay. And again, environmental tobacco smoke endangers non-smokers as well. And if you think the fact that I stopped, which on June 20th will be 17 years ago, okay, makes me less likely to get cancer, you're wrong. My risk of cancer is permanently elevated because of that year. We do what's called pack years. Number of packs a day times the number of years you've smoked. And so if you interview a smoker, you're doing an intake, let's say if you're doing a nursing assessment, or you're doing, oh, by the way, sir or madam, do you smoke cigarettes? Yes. About how much do you smoke? Half a pack. That's at least a pack. Believe me, it's like, how much do you drink? They're all round up. 2 or 3 a day, that's the better part of it. Okay, trust me. And then so figure, even whatever they tell you, let's say a pack a day for 10 years, now you have a 10-pack year history. You're already on the road, and about roughly with 20-pack years, I had 80. Okay, by 20-pack years, that will permanently increase your risk that anytime they find a, quote, spot in your lung, a lesion or irregularity in the lung on an x-ray, it's an 85% chance it will be cancer. That will never look. Your lining will get better, your cilia will be replaced, your epithelial cells. It gives you an idea. And it's a very good lecture to give to smokers if you're so inclined. It's hard. It was very hard for me because I had family members telling, I'd have to give temperance lectures telling people not to drink and not to smoke. It's not the easiest discussion to have with somebody. Unfortunately, and as a healthcare professional, you're stuck with that sometimes. So that's part of it. Notice normal, notice that. Very persuasive. Okay. The throat, your pharynx. Just a fancy name for throat. We review this in both digestive and because it's a shared system. You have 3 parts of it behind your nose, nasopharynx. The opening of the auditory tube is significant anatomically. Oro, behind the mouth, and laryngo, basically below the oropharynx and kind of behind the larynx, which is your voice box, if you want to think of it simplistically, and where effectively the start is of the esophagus, where the pharynx terminates and forms, basically goes from one tube into 2 distinct tubes, one short, one long. We'll get there. So the larynx that surrounds it is the enlargement in the airway portion. Okay. So it's easier to see, to describe from a diagram. Effectively, this shared passageway we call the throat terminates. Somebody turn it off. I keep thinking my wife wants me. Okay. So understand that terminates at a structure called the epiglottis. The epiglottis is unique in everywhere but your ear because it's the only place with elastic cartilage. Okay, other than your ears themselves. And the epiglottis, when we swallow, it's designed to flap down and cover the anterior divide of that tube, which becomes your larynx and eventually into your trachea and into your lungs, and allow the opening to remain open that has been created of the esophagus where food will pass, which is posterior to it. That's the epiglottis' whole job. Okay? And so that structure that surrounds this, sort of the top of the structure kind of starts With your hyoid bone, you might remember that's a bone that basically sort of like an anchoring bone for muscles and tendons and ligaments, doesn't articulate or meet any other bone. It forms in there sort of as a platform for swallowing and speaking. Okay, and below it is where we see the start of this apparatus we call the larynx, highlighted by your voice box on the interior. So you have three large cartilages. Those are the ones I would make sure that you knew about. If not for me, I would certainly think you need to know about that for lab. And the thyroid cartilage is the largest, and it has a prominence that develops and increases in size starting at puberty. It's larger in the male typically than the female, though not exclusively so, that you and I call the Adam's apple. It's also known as the thyroid prominence or eminence. And then you have the cricoid cartilage, which is another cartilage below it. Both of these are effectively ring-like structures. The thyroid cartilage is larger anteriorly, the cricoid posteriorly. And what cartilage does in the respiratory system is make sure the airway stays open. That's its job. It's flexible. It gives way, with the exception of the epiglottis. It is all hyaline cartilage. This is the anatomy. So there's inherently a certain amount of flexibility or give. And wherever we have cartilage, it's there so that if there is a spasm, like if someone has an asthmatic attack and it squeezes the tiny bronchi, the ones that don't squeeze and have to stay open a little bit are ones that have cartilage in them. The cartilage, as long as there's a sufficient amount, can't be squeezed by the smooth muscle going into spasm, what we call bronchospasm. And you all know somebody, maybe you have one, who has an inhaler designed to combat those kinds of things. There's nothing unusual about that whatsoever. There's three pairs of small cartilage, which names I never have students know: a retinoid creniculated cuneiform, that's medical school anatomy, that type of stuff. So they'll have the diagrams that will show it. These, you always see the same diagram. This is anterior. Here's that hyoid bone. You can see the very top of the epiglottis. That's the part that's going to flap down and cover this portion and leave the opening more posteriorly. So, and here you can see a fairly substantial ligament between the hyoid bone. It's typical, it's like a U-shaped bone. The thyroid cartilage, which is a ring, but broader and wider, and certainly distinctly anterior where the evidence is. The cricoid, you can see it much thinner, but when you go backwards, here's the back of the cricoid. Get the idea? So it's thyroid wider in the front, with the prominence, cricoid wider in the back. And it gives way to the C-shaped rings of the trachea. And the tracheal rings are C-shaped, open posteriorly. Okay, and what they have is that basically this trachealis muscle is there, even though short answer is I'm not sure if that's classified as a skeletal muscle, but when you, like you were just coughing, that trachealis muscle helps you express if you've got, phlegm or mucus stuck in there, something you have to, get out of that area to clear your throat. Okay. Plus, it's, what else, that opening is handy because it can give, and whenever you swallow, your esophagus, which is sort of like a flat tube, when you swallow, like a lot of your digestive system, it expands. Imagine if this was a solid ring, and if you're like me and occasionally, do the 2-bite sandwich, the whole pizza at once. I told you, I always cut it into 8 pieces. I can't eat 6. The other way around. I know. Do you know what I'm talking about? You take entirely too much in, it would get stuck. Not good. Yeah, bad. Stuck is bad. It's like my mom said, chew your food 26 times. Our moms of my age all said that. I don't know why. They were in love with the number. You'll be happy. I do not do the vocal cords. They confuse me, and if it confuses me, why should I try to confuse you? You want to know the vocal cords? Go to somebody who knows the vocal cords. Maybe Dr. Robbins is more vocally cord adept than I am. So I'm not going to look at false chords, true vocal cords, false vocal cords that might be lying, but maybe not. You could have laughed at least. You're usually good like that. And then here they're opening and closing. There they are. That's what they look like in real life. They're really important. You can see that. And so that's the anatomy du jour. Trachea, flexible. You blew up that poor sheep's throat, right? And lip. Wasn't that nice and flexible, that trachea? Ours is not a whole lot different, albeit a little bit bigger. As you can see, the diameter, that's an inch. And it's about, as you can see, about 5 inches in length, downward, anterior to the end. It divides. Again, it divides. The termination of that, and you'll see the name again here, is called the carina, C-A-R-I-N-A. And that area of division or bifurcation, in other words, forking into the right and left primary bronchi. Okay. Again, ciliated, mucus, pseudostratified, goblet cells, approximately, there's number varies. 20 is a good number. You could be as maybe 12 to 20, depending on the length, which varies. And this is when you do have to, basically, tracheostomies are used when the airway is clogged at this level. There's swelling, there's inflammation, there is disease entity, there's trauma. So you're basically, the ostomy is created here. That's that neat little notch. Remember this from anatomy, the sternum? It's the xiphoid, the body, and the manubrium. The manubrial notch or sternal notch is midline, and that's your guidepost. Whenever you're going to trach somebody, you go midline, because you're safe. What's over here are big blood vessels, jugulars, and carotids. Oh, no, bad juju there. Right here. That's what you use it for. And you can feel, I mean, I'm not suggesting anybody has to do them like that, but that's the anatomical landmark. Somebody, let's say a physician has to come in and trach somebody. That's what they're going to do. Inserting a tube, if an object is lodged in the larynx, and I mean, you've got to make sure that my first wife, a little kid, I remember just now, she was the head nurse ER, our not community hospital, a little 200-bed inner city hospital, and a little kid, and they had like those, like the fake fruit bowl, swallowed a grape, fake grape, lodged in his throat, and we had instrumentation, but not the absolute best instrumentation for children. And the only place that had it was Children's Hospital in Philadelphia, which is a wonderful facility. Our facility was it was a standard emergency room, just general hospital emergency room. She took the ride in the ambulance to Children's to deliver him to their emergency services, where they obviously had the problems they dealt with kids. She had to hold the kid upside down. Because anytime he started to get right side up, it clogged. He couldn't breathe. Oh, that must have. She said it was an amazing ride there. You're keeping this child alive. I mean, because if you're going from North Philly to not Center City, to the university area, if you have any idea about Philadelphia, by University of Pennsylvania, where Children's is, it's not a short ride, but you could get traffic. 15, 20, even an ambulance screaming away. Busy city. Little things you might have to do depending on where you're going. Okay, here it is. This is what I'm talking about. So up there you can see, this is really, when you talk about lower, this is lower. So to me, I would agree. I really think from an anatomical perspective, yeah, it really starts there. From an infection perspective, maybe not. I have to think you have to get into the trachea. And then what happens, here's the carina, that sort of triangular shaped cartilage. And the big difference between the right and left main bronchi is directionality. The right is by definition wider, points more downward. And again, more particles go that way. The left basically is much more horizontal because it has to get over the heart. And then we have significant difference between the two, not the total amount of lung. I mean, most anatomists will tell you they're nearly equal. Maybe the right is a skosh bigger, just because the heart is occupying some of the volume. The right has one main bronchus. It divides twice. And what that does is it creates 3 secondary bronchi, which they call lobar because it has 3 lobes. So here's the main one. It gives a big branch there. That makes the superior lobe. A second branch here, the middle lobe, and the completion or the termination or the continuation is a better word. The primary bronchus becomes the lower lobe or inferior lobe bronchi. Those are secondary. Anything that branches off of there are tertiary. Nowadays we call them segmental bronchi. We used to call them lobular bronchi. So, and what's different on the left is you only have one division. So you only have a superior and one branch off that creates the inferior. 2 lobes on the left, thank you very much. 3 lobes on the right. There's roughly the same number of segments. There's consistently, anatomists find 10 segments on the right and usually 9 or 10 segments on the left, though I have seen numbers published as low as 8 on that. And after that, it just keeps dividing. 23 orders of division, and the bronchi keep getting smaller. So after the tertiary or segmental bronchi, these guys, we don't have a name. We just call them bronchi. When they get to be around less than a millimeter in diameter, okay, and they're all rings of cartilage, by the way. So no problem with air getting through there. None whatsoever. As they get small enough where you begin to not see them, they become bronchioles. Remember, that's a diminutive suffix, that O-L-E-S. They're like arterioles. Now, the bronchioles, those rings, gradually are replaced by plates, and where it's not plates, it's smooth muscle. Eventually, as it gets small enough, those... Okay, fine. Now, a letter from the boss. This requires a yes to you. We'll make it a will do. All right. Been a wonderful 20 years. I've been continuously married for approaching 50 years, just not to the same person. Moving on. And so when it gets to the point where the rings are replaced by the plates, okay, at that point in time, effectively, when the smooth, that's when spasms of the bronchi, say from severe allergic response or asthma or whatever you want to call it, or even anaphylactic shock, will clamp down and it'll just, that little plate of cartilage will not stop it from closing off air. And frankly, at that point in time, it's still air getting to the point of exchange. So it'll block one's ability to effectively breathe oxygen and carbon dioxide. That's the idea. And they're showing it to you a little bit here anatomically. You can see the location here. Here's what I was just telling you. And it just keeps making these successive division from main, primary, lobar, secondary, segmental, tertiary, and then smaller and smaller. When it finally gets to these tiny lobules, these little subsegments, as I said, you can see 8 on the left and 10 on the right. There's different numbers with different authors. The terminal bronchioles are very, very tiny, and they open up into respiratory bronchioles. The terminal bronchiole is the end of the conductive system. The respiratory bronchioles are where they first conduct gas exchange. How do we know we're there? We see alveoli budding from it. Once the alveoli start to pouch out, these little, effectively like grapes, or grape-like clusters is the way most of us describe them. And then there's other anatomy. There's ducts themselves, which are branches of the respiratory bronchioles, which are always end in alveolar sacs. And the sacs are these large groups of them, and the individual alveoli is an individual sac. And I'll show it to you anatomically. And it's a classic because every order here, when you're entering the lung, what accompanies it? A pulmonary artery. And what returns the blood? A pulmonary vein. Remember, we did this in circulation. And so you get Eventually you get pulmonary arterioles at this level and pulmonary venules at this level, and this is surrounded by pulmonary capillary beds. And the beauty of this whole system anatomically is you have effectively simple squamous lining on the blood vessel, on the capillary endothelium, simple squamous lining in the alveoli, because all that is really a simple squamous cell, and they're being held together by, imagine like a very, very thin piece of paper that they share in between them. So it's a common, we call a common base membrane. It's very permeable to oxygen and carbon dioxide. It gets right through. That's all it is. So it's instantaneous under normal circumstances, the exchange of oxygen and carbon dioxide. We'll get into the physiology of it, but not today. That comes later in this particular chapter. That's why I wanted to review it. See what I mean? They're like, oh, it's like a bunch of grapes. Okay, and you can see how they open up, and these are just like, again, like puzzle balls of cells. And they're all over. They're on the sides, they're in the front. The bronchi and all those divisions are more centrally placed. So anteriorly, posteriorly, laterally, even medial to them is where much of what we call the fancy words called parenchyma, Parenchyma, that you don't have to know now. It's sort of like the meat of any organ. Voila. So there's, you always see this illustration. All these orders of branching, there's a lot. And you always see this. Okay, this is shown where you can see the thickenings here. Those are where you have smooth muscle and cartilage. This is all air. These are all the alveolar cells. This is relatively normal. Okay, and so you can see it's a little bit here. You can see all the little air spaces. When these start to get destroyed, all the little tiny walls that are there, and then you see thickening around them, but in a wide band with not a lot in the middle, that's the highlight of emphysema. That's what emphysema looks like. The air gets trapped. And the big problem is now that trapped air makes that space for oxygen and carbon dioxide exchange useless. And what we will learn about, undoubtedly starting next week, is something called, it diminishes something called your vital capacity. And that's your vital capacity is critical, because that's what allows your lungs to have the capacity to keep up with moving oxygen and carbon dioxide sufficiently to meet whatever needs your heart has. So whether your heart's pumping out normally, let's say at 75, or you're doing a workout and your heart's pumping up at 130, you have the ability and basically the space to do those exchanges, whatever the degree of need. When they don't meet each other, so again, here are the rings, they become narrower, cartilage decreases, cartilage begins to disappear as we get into the bronchioles. Okay, smooth muscle more prominent, what I was telling you. Pseudostratified is in the larger tubes, and then as you get to those respiratory bronchioles, effectively we're not as concerned. Mucus would only plug it up. The cells that you have in there that help get rid of things are a whole bunch of macrophages. You have respiratory macrophages, and again, they're like these little sweepers that sweep up debris, any particles that might get in there. And so now we see a transition to simple cuboidal. And when you finally get for the exchange, you need the thinnest possible membrane. And the beauty of simple squamous cells, they have a nucleus. They're like a giant fried egg, where you have tiny yolk and a whole lot of white. I'm thinking sunny side up for those of you in the egg description. They must have. Did they have that up at the church? The extravaganza? You know, up there. My wife was there Sunday for services. Victory. Up on the hill in 19. But that giant church up there. My daughter they have the extravaganza, this big party for like the week prior to, like the weekend prior to Easter, and they have vendors and games and stuff. And she had like a lemonade cart. So my previous boyfriend, not the one she's married to. So, etc. Bronchial tree, transporting air, alveoli, surface area for gas exchange. Only structures that contain alveoli can do that. Okay, so it's respiratory bronchioles to alveoli. They don't have that. They don't have alveoli on them or out pouching from them. No exchange takes place, etc. And oxygen goes in, and we do that already. Voila. So you always see this gives you an idea of sort of the intimate association between blood vessels, alveoli, this immense capillary bed, if you can discern that. Here you can see what I mean by a puzzle ball. These are all simple squamous cells. And again, they're sharing that membrane. The capillaries cells are here, the alveolar cells are here. And that's simple diffusion 101 in its most elemental way. Okay, you knew this from lab, soft and spongy, all the lobes. The area where they enter is called the hilum. This is also lab stuff. Okay, linings. So we refer to the, remember, in the thoracic cavity, you have the mid layer, the mediastinum. This is anatomy 101. Mediastinum or mid-sternal area, you have the pericardial cavity, and above that you have the trachea and related structures. On either side, you have closed spaces called pleural cavities, one on the right and one on the left, containing your lungs. The lining around the lung is the visceral pleura. We've had this all before. The lining on the walls is the parietal pleura. What's important about that, they help you breathe. Those are moist linings. They're in relatively close proximity. There's a tiny amount of space. So when we inhale, okay, we take that breath, we're lowering our diaphragm, we're expanding our rib cage. Okay, we're expanding the structures that are on the parietal pleura because of surface tension with the fluid that's in there on between the parietal and the visceral pleura, that helps to pull out your lungs. It's not just atmospheric pressure, but that plays a significant role. It's also that surface tension of fluid. Okay, so we underestimate how important that bit of structure is that are there. So these are serous. Serous is different from mucus. It's mostly fluid and some chemicals and salts in it. Very, very little, if any, protein. That's what makes it serous. Mucus is just that. It's got more protein and it's sticky. So voila, here you are. They're showing you all that good stuff before. You see this all the time, etc. I mean, so these, and what's neat about these being isolated structures, these are three closed spaces. So when one is damaged, and understand this, when we get to this whole system is based on negative pressure. There's more pressure outside than inside. So that quote unquote suction pressure, that atmospheric pressure being less in the interior, constantly allows a certain amount of air to be inside. That keeps your lungs inflated. It's very bad if your lungs deflate. We have a word for that. Collapsed lungs. But fortunately, typically, this is the kind of thing that happens with a traumatic accident. Okay? Before airbags, it was probably more common. It still could happen. It can happen with sharp force trauma, gunshots, stab wounds, those kinds of things. And what happens whenever that pleura is disrupted, parietal or visceral, it allows air to get in. That immediately disrupts the whole thing, and the air will cause the lung to collapse. And if you must reinflate it, because once it collapses, once those alveoli and those lung structures start to stick to each other, they get progressively more and more difficult to re-expand, and you begin to lose those sections of the lungs functional. That's why we reinflate them. We reinflate them by inserting a tube into the area and sucking out the air that's in there to, bring it back to the appropriate pressure, and eventually taking the tube out as it begins to heal. Well, it's called passing a chest tube. So this just summarizes all that stuff. Easy enough. Interesting. Stuff that's irritant. And you've heard about this because you hear about it on TV. For years, there was very little about asbestos. It was in shingles, it was in older buildings. And they found that people who inhaled asbestos got asbestosis because those fibers would damage the lung and would cause a particularly unique cancer called a mesothelioma. So that's a cancer. The mesothelium are the lining cells of the pleura, and that person is not going to survive. You're going to die. And so and as attorneys are wont to do, they realize that's sort of a slam dunk case, and so that's going to be money for them and money for the patient, for their clients, so to speak. So and over the years we've seen less. It's interesting. Those are the kinds of things you start thinking about in older buildings that were grandfathered into code, that kind of stuff. It's like having lead in paint. We used to have a lot of lead in paint. And now it's an older building, and little kids, paints would chip off in old buildings. We see them in tenements and slums in the big city. And I don't know how much of that occurs here in Pittsburgh. I remember I grew up, 20 miles from New York City. A lot more stuff going on. I mean, I grew up in an urban environment. Started there, moved to a suburban. Beryllium is something else, mostly industrial. And again, these are all problems. Allergies certainly are part of the problem. Breathing impairment, air pollution, all of those can work. There's so many different things. We've gotten to the point now where you're seeing not just healthcare facilities, but facilities in general, trying to stay away from things that could be irritant. Cleaning solutions that are more, if you will, eco-friendly. What that means is you're not using things that have a lot of chlorine in them, things that people would have difficulty breathing, and things like that. So there's a lot, and this city was pollution central for a very long time. It was the steel industry. I mean, all we had were basic industries: steel, chemical plants. I mean, it's still there. Up until my son moved down to Florida, he was working on Neville Island over here, next to the big Ineos chemical plant. It is not easy to breathe. I mean, so this here was a particularly bad area. They still have a lot of chemical plants here because they're still zoned to permit it. You see that the people don't live on that side; they live on the side close to the skating rink. So moving on. So this is more about the physiology portion of it as we begin moving air in and out, inhaling and exhaling. Okay, and that's one cycle. And this is what we begin to look at. I don't go crazy over these things. They are based on something that you may or may not have had when you were in high school, called the ideal gas law. Is that ringing a bell? Okay, all it means, you don't have to, I'm not going to ask you to do anything about it. All these laws kind of come off of the ideal gas. And all it means, very simply, is that pressure and volume have a constant relationship. Okay, that N is a constant, R is a constant, T is a constant. Okay, and so what happens when we decrease the volume by inhaling, it decreases the pressure. Okay, when we exhale and lower the volume, we basically increase the pressure, and it helps us expel it. So there's a constant relationship between pressure and volume. Volume goes up, pressure goes down. That's all it means. And all of these laws that you see inevitably in these anatomy and physiology textbooks relate to this. They're variations that have been developed off the ideal gas law. So they're inversely proportional. Why didn't I say that? Okay. As the pressure inside the alveoli decreases, air comes in. This occurs normally at rest. Okay. And so what happens, and they're talking about what's going on. The volume of the thoracic cavity increases, decreasing the pressure more. It's misspoken here. Okay. What they're saying is atmospheric pressure and alveolar pressure equal. Not quite. There is a certain inherent difference that allows air to come in. So that because again, if it was equal, there would be a greater tendency for those alveoli to rub against each other and adhere. So there's always some residual air in there to allow it to adhere. So again, I don't go into this part of the physiology in detail because I don't want to, for your sake. It's actually about maybe 4 millimeters of mercury difference in reality. And when you and I inhale, okay, we'd probably add another couple of degrees of millimeters of mercury. So maybe the difference is 4, now it's 6. And that's enough to bring the air in very efficiently. So, I mean, I'm not going to go into all the numbers, and you kind of get down to that 754, don't care. Okay? What happens when you breathe, the only part where you and I expend energy breathing is inhaling. We lower our diaphragm and we use our external intercostal muscles. The only time we use energy exhaling is if we have to like blow out the candles or strain or forcibly exhale. Other than that, just relaxing the muscles that we used and the elasticity of the system is sufficient. So exhaling is passive, inhaling is active. Surface tension I talked to you about, the surfactant that's produced by what are called type 2 cells. Surfactant resists the tendency for the for the alveoli to stick together. It's a wetting agent. It's kind of like an intracellular detergent. And so when we have to deeply inhale or deeply exhale, then we use other muscles. Let's leave it here, and we'll start with this idea of what happens when you breathe on Monday. Thank you.